My name's John.
My name's Phil.
We're here today in partnership with IPC Partners and Tristel to talk about biofilms, drains, and some solutions. So we've heard quite a lot about biofilms and potential risks in drains and other parts of the hospital earlier, with talks from Mark Garvey and Jean-Yves Mayard. What we're going to try and do in the next half an hour is work with you to try and get some of your views and expertise to think along the lines of some solutions to some of these problems. Unfortunately, I'm going to spoil the plot and tell you there is no good single solution to this problem. So I'm sorry about that. So I can't give you a perfect solution, but hopefully together we can move some way towards at least risk mitigation for some of these complicated challenges in healthcare. You'll see on the slide, just over Phil's right shoulder, there's a Mentimeter poll, so please do scan that QR code and get the Mentimeter going. We want to hear from everybody in the room. We're going to have 4 polls throughout the session and a little bit of time for open Q&A at the end. So without further ado, I'm going to hand over to Phil.
Yeah, thanks, John. Welcome back, everybody. So we're going to talk today about something which I personally am really passionate about, biofilms and drains and their kind of role in infection transmission and IPC. And hopefully, like John said, work with you guys to try and understand some of the challenges and what you're doing in your own organizations to try and circumvent the threat. So just really briefly, this is what we're going to cover. We've broken the talk down into 3 sections. We're going to talk a little bit about the background and the importance, recapping on some of the previous speakers' work. Then John is going to talk about what our options are and what they look like. And then we're going to talk about and focus in on some of the chemical approaches with a real focus on chlorine dioxide. So we're going to start with a poll, and we'd love to hear from you in the audience. So we just want to understand about where you personally rank the following in terms of transmission of microbes that can cause healthcare-associated infections. So which one of these from that list of hands, drains, endoscopes, and shared medical equipment do you think are the highest or the lowest risk of transmission within healthcare?
Am I allowed to do the poll, Phil?
You can. You're going to choose drains, right? Okay, we've got 43, 44, 46. Good, 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 good. It's ticking up nicely. Okay, can we have a look at the results, please? Okay, hands, number 1. Drains, number 2. Shared medical equipment, number 3. And endoscopes, number 4. I thought if I had to predict, then it would be hands for me. What did you put, John?
I didn't have time to do it, you were too quick. But what I would have put is shared medical equipment as the primary risk of that list.
Okay.
Followed by drains.
Okay, so hands is lower down the risk for John. So that poll will stay open now in your phones or in your apps. If we can go back to the presentation, please. And then you'll be able to answer the subsequent polls in a couple of slides' time. So we've heard a lot today about the role of drains in healthcare, and I just really want to hammer home this message about when we're thinking about how we disinfect or try and eliminate biofilms in wet environments, the diversity of microorganisms that we're dealing with is really complex. So it's not as simple as us saying we need a disinfectant that is going to be active against X. It needs to be active against A, B, C, D, E, F, and G. So it needs to be really highly efficacious. And this pie chart here just shows the diversity using some molecular techniques about what you might actually interpret or see down in a biofilm. And there's lots of gram-negatives, as you'd expect there, but some really diverse kind of microbiological profiles there as well. We know as well that the evidence base for drain disinfection and the role of biofilms in transmission is building. That evidence base is building nicely, and we're going to talk about a couple of studies. I also think that because drains and the way that they are positioned and the way that they are kind of out of sight, out of mind, we perhaps probably look last there as a source for them to be a transmission outbreak. But we know now we've got lots of good published research which shows that drains do play a role and biofilms in the transmission of infections. So you've already heard Mark talk about the splash zone, and I just want to go into it in a bit more detail because the one thing Mark didn't talk about was just the diversity of different clinical equipment that was found within that splash zone. So I think if you go and read the paper, there are something like 12 or 14 different categories of different medical equipment within that. And we've just highlighted a couple of them here. So intravenous equipment, 65% of the intravenous equipment they accessed or surveyed was in that splash zone. So again, just trying to paint this picture of transmission from biofilm within sink being aerosolized through water or splashing and then contaminating the patient environment. And I really like what Mark said about trying to develop this almost red tape zone around sinks where there's a danger of transmission, and can you keep that area free from clutter? Very difficult in an intensive care unit because of the complexity of the patient needs, but something for us to think about. Personal care as well, really high from that list. So we're just going to talk a little bit about biofilms, and we've put this on there just to show you about how they develop and how they evolve. So you start with microbial attachment to a surface, and then the organisms start to proliferate, and they start to produce this really gloopy exopolymeric substance and slime. And that slime is a real consideration when it comes to thinking about how we're going to eradicate that biofilm from a wet environment, because it poses lots of challenges from a disinfection perspective. The organisms then become established and really hard to remove, but they can also break off and go and seed other environments as well. So you kind of have this ongoing cycle of attachment, proliferation, and then potential detachment as well. And these organisms really proliferate in nutrient-rich environments such as drains. One of the speakers this morning talked about observing behaviors by using hand-washing basins. 20% was the figure quoted. I've seen studies which show that hand hygiene accounted for 5% of all activities in a hand-washing sink. So think about what we're doing when we're putting things like medicines or IV fluids down those drains. We're seeding those microorganisms and developing even better conditions for them to thrive. Okay, we've got another poll now. We now want to ask you about whether or not you kind of agree or disagree with this statement. So do you think that drains are an important reservoir for transmission within healthcare? I think given what we've heard this morning, I'm definitely on the strongly agree one. It's great to see we've got so many people logged into the poll as well. I can see we've got 127 people logged in, which is fantastic. So results are coming in. We're about halfway. John, what would you have said?
Strongly agree.
Same as me. Okay, I'll give it 10 more seconds.
But I would also say there's quite a lot of uncertainty about the answer. Mm-hmm. I think I strongly agree. I'm sounding really uncertain, aren't I?
You're undermining me while I'm speaking. Okay, let's go to the results. We're 121. Fantastic, wow.
Wow, look at that.
That's a really nice way to present the data. So 5 being strongly agree, we're at 4.6. So I think that we can agree that everybody in the room thinks that drains do play a role within transmission. And I think I would say that that evidence base, as we talked about in the first slide, is definitely building. If we can go back to the presentation, please. So just thinking about what do we do with this problem when we know that biofilms are there. And this is an image taken from a paper by one of the previous speakers, Ronnie Ismailad, who I had the pleasure of doing some work with down in Cardiff. It's quite a complex slide. There's a lot going on. But what the slide is designed to illustrate to you in the audience is that biofilms, by their physiological state, mean that disinfectants have to work really, really hard to eradicate them. So I'll just pick out a couple of examples. The slime around the biofilm means that it's very difficult for disinfectants to penetrate that slime and get in and actively kill the microorganisms. We also know that biofilms and organisms within biofilms grow at a slower rate. Things like antibiotics and disinfectants work against fast-dividing cells. So again, it's a challenge about how they work against slow-growing or slow-growing dividing organisms. And we know that the susceptibility reduces by several orders of magnitude. And there's some of these kind of other traditional or non-traditional mechanisms of resistance that we don't normally associate with disinfectants or antibiotics from biofilms. Okay, my final slide before I go to John is just kind of giving and confirming that evidence. So this is the Fucini study that looked at infection rates in side rooms and intensive care units, I think in 52 different ITUs in Germany. And they basically looked to compare infection rates in side rooms with sinks and without. And lo and behold, the rooms with sinks in them had higher infection rates. So I think that's some of the best evidence that we have that links sinks and biofilms to the role of transmission. And in some of these studies, if you go looking in the literature as well, we know that these infections can last long periods of time. Because as we said earlier, out of sight, out of mind means that we probably look in the sinks in the last place. So do we need to start being more proactive when we've got these outbreaks where we can't quite establish where the source is? Do we need to start going a little bit earlier and looking at sinks and biofilms? Okay, thanks. I'm going to pass to John.
Okay, thanks, Phil. So let's just have a think about what we're trying to achieve with disinfection of a sink drain. Is it realistic to eliminate microbial life in a complex environment of a sink drain? No, it's not. No, we're never going to achieve that. And if we achieve that, it will be a very transient success. We've seen previously how very quickly there's a rebound effect following disinfection of a drain or even a replacement of a drain. Eventually it becomes recontaminated. So for me, I think the objective here is a continual process of risk management. The open question is what's the most effective way to achieve that end? So thinking about how biofilms fit in the kind of hierarchy of disinfectant effectiveness, this is a common pyramid that you will have seen before, with the most challenging to disinfect microbes at the top, which we would usually recognize as bacterial endospores, and the easiest microbes to inactivate towards the bottom, things like the envelope viruses that don't survive long on surfaces and can be inactivated quite quickly. Bacteria, microbes in a biofilm form in a drain challenge in a way this hierarchy, because even a vegetative bacterium encased in a biofilm could be a lot harder to kill than, let's say, a naked, is that the right phrase? You know what I mean. A naked bacterial endospore without any EPS or any other challenge to the disinfectant penetrating the microbe. So could it be that bacteria in a biofilm mode are actually right at the top of this triangle of disinfectant effectiveness? I think that's probably a fair way to reflect the challenge that we face. That probably is a reasonable cross-section image of many hospital pipes with very, very thick, challenging disinfection scenarios. So I think part of this process is around physical removal of dirt and organic matter to allow disinfection to occur. So I think we've probably got principally 4 options to consider when it comes to disinfecting a drain. We can look at thermal. We know microbes don't like extreme heat, and that could be via hot water or steam. We've got chemical, various different chemistries we could apply with advantages and disadvantages. We have physical approaches, so getting your bottle brush down the sink in a sort of modern way, or taking the sink or the pipework away altogether. And there are some emerging technologies, perhaps looking to maybe gaseous methods to try and reduce, or something like UV, firing across ultrasound as another potential approach. So I'm really interested to see the result of this next poll. If we can go to the live version, please. What strategies do you use to address drain contamination in your institution? Do you use thermal, chemical, removal of sinks, a combination, or none of the above? What would you be saying to this, Phil?
Principally chemical, but removal as well, where we haven't been able to establish or remove the outbreak.
Okay, yes, I mean, similar for us, we're going through a program of removal of sinks at the moment in some of our sites, and also some chemical treatments in some settings. It's a bit of a mixed economy, so I'd choose a combination here. Okay, can we go to the live result? Okay, so majority chemical only. Next up, combination. Quite a lot in the none box as well. I think that's probably as expected. Thanks, everyone. That's really interesting. Can we go back to the slides? Okay. So very briefly then, just a quick look at those 3 main approaches we might take. So starting with thermal, then chemical, and then physical approaches. So thermal, what we need to achieve is a high temperature flushing, which disrupts the physical EPS and also inactivates the microbes. We know that steam penetrates the biofilm matrix better than hot water. Limitations, though, difficult to get that high temperature throughout all the complicated pipe work. I mean, it's difficult to get hot water supply throughout the complicated pipeway, let alone the kind of disinfection levels we'd need to achieve. So I feel like this could be applied locally, but system-wide would be very tricky. Chemical approaches, the front runners probably are things like chlorine dioxide, bleaching, quaternary ammonium compounds, so mainly the oxidizing disinfectants. There's recognition that foaming is probably required. If you pour a liquid disinfectant down a sink, where's it going to go? Straight down the drain with limited contact time. That's not going to do the job we want to achieve. Activity in the presence of organic matter is crucial given what's down the sinks and the drains. Challenges here with penetration, efficacy by chemistry, some are broader than others, and the impact of organic load. And how do we achieve that contact time that we're going to need in order to get the level of efficacy that is required? Finally, thinking about removal, how can that help us? So in a way, the gold standard is the complete removal of a sink. That takes away the problem. Although, look out for dead legs you might leave behind in your system. So that this needs to be a carefully planned strategy. But we do need sinks and drains in our healthcare provision. We can't go completely water-free. We need to move to water light as a strategy. An alternative physical approach is not, rather than removing the sink itself, physically removing the biofilm. And I think there's some mileage in this and exploring this, and whether there's some new tools we might need to do this most effectively. I'm thinking about my block drain at home the other day. They came with their clever little drain rod and the camera going down to see what was happening. You know, we could think about that sort of approach, and that might help us in some settings. Limitations, though, it's expensive. It requires infrastructure change, disruption to clinical areas, and at the end of the day, if we have a sink, we will have biofilm reforming. So it's not a panacea or a one-shot solution to this, but it could be part of an overall risk mitigation strategy.
Thanks, John. So John's given us a really nice overview there of some of the options available to us. We didn't have time to talk about some of the others as well. So design, for example, how you can maybe design out risk from splashing. And there's some really interesting innovations as well coming around things like plasma, UVC, and vibration as well. So there is plenty out there. And I think innovation in this sector is really, really important to try and overcome this challenge. Okay, we're doing really well for time, and we want to make sure that we have some Q&A at the end. We came up with this list of what we think you need from a chemical drain disinfectant, and it's really long. I'm not going to go through all of them in detail, but I think what we've tried to highlight is the complexity of the challenge, and that it isn't as simple as putting a chemical down the sink. You need to think about lots of the other competing factors. The main one that I think I want to talk about is that when you think about a biofilm, we've talked about the challenges of how you have to be effective against lots of different microorganism groups or different species of bacteria. But you probably need a really high log reduction as well, because that matrix is probably encompassing billions of organisms. So you need a really high log reduction, and you probably need quite a long contact time. So we've talked about the importance of possibly having a foaming element to a drain disinfectant. I think that's good to ensure that you navigate that complex geometry of your pipework. And I think the feedback that I've heard from speaking to people who are trying to work with this problem in the front line is that every drain is different. So how can we have an approach which will fit different pipe geometries and different challenges as well? I think the other thing we need to think about really carefully about as well is compatibility with our pipework. The last thing we want to do is start putting really corrosive, dangerous chemicals down, which often is the go-to because we know we need that real high killing power. So we need to think about products that are compatible with our pipework so they don't cause long-term damage. I think we need to get to cost effectiveness as well, and I don't think we're anywhere near this at the moment. We're just seeing and appreciating the role of drains and biofilm in transmission. I think our next step is to see about how these new interventions that we've talked about actually are cost effective for our organizations. Because I think from an IPC perspective, this is a fairly novel problem. We've always known about drains and biofilm, but I think now we've got the evidence to link that to transmission. The minute that I say to my clinical procurement specialist that I need to spend X amount on disinfecting our drains every month, there's no price to compare it against. So how can I show that intervention is cost effective? So Jean-Yves talked really nicely earlier about the different mechanisms to assess performance. And again, this is just to highlight that we don't really have that standardization yet. We do have some methods available. But I think why I want to see the evidence shift is away from the laboratory testing and some of the standards that are out there, things like minimum biofilm eradication concentration, or MBEC, is to more real-world data. So how can we show that chemical approaches or other interventions are independently validated, and what that looks like in a real-world setting? Because it's great to see that the product performs really well in a lab setting, but I want to know how that performs in a clinical environment when people are using that sink on a regular basis, when they're putting things down it that they shouldn't be, etc. So this kind of links into what the key characteristics are that we talked about on the previous slide. I personally would love to see a standard or a test which takes into account all these different considerations. So looking at log reduction, i.e. the number of microorganisms that it eradicates, efficacy against multi-species biofilm, not just against single species, having its ability to penetrate that exo slime and ensuring that the disinfectant still remains efficacious, that it has maybe some residual effect, or it gets the numbers in the biofilm down to a low enough number that it doesn't mean that 24 hours later we're going to get really high log reductions again, because these organisms will proliferate and come back really quickly. Real-world conditions we've talked about, and then a big consideration as well is the activity in presence of organic matter. We know that we're not just trying to tackle microorganisms. We know we've got competing challenges from things like, dirt and lots of other wonderful things that we see being put down sinks. So our final poll really is just to ask you guys' views on where you think we should be ranking the most important characteristic of a disinfectant. So if you haven't already scanned the QR code, there's a chance to do that again. We want you to basically rank where you think, from this list, the most important characteristic of a disinfectant used to decontaminate drains is. So you've got efficacy, material compatibility, safety, or residual activity. 175 people logged in, fantastic. So this one takes a little bit longer because you've got to fiddle around, and you can drag and drop the options to be able to kind of move them up. Just while we're waiting, I think, for me, it's between efficacy and residual activity. I think efficacy is really important, but I'd love to have something which shows me that the biofilm doesn't come back. But I think that is probably linked to efficacy because you've got to get the numbers down really low to begin with. John? Yeah,
I actually see this differently. I think safety has got to come top, right? Because if we have a product that's not safe to use, however so defined, then forget the rest.
We don't usually argue, but today could be the first time. Okay, let's go to the results, please. Thank you. Okay. No, John. So efficacy number one. Safety second, though, so we're not too far away. But I do agree with John. A product which is safe is really, really important. Okay, thank you very much, guys. Let's go back to the next one. John, I think you're going to take us through here.
Okay, so thinking about potential candidate chemistries, we've selected chlorine dioxide as almost an exemplar case study to think about how it maps against those moon on a stick characteristics of the ideal disinfectant for this application. I'm keen to go for an oxidizing chemistry for dealing with biofilms. From the review I did 10 years ago now, but I'm sure it's still true, it was the oxidizing chemistries that had the ability to both penetrate the biofilm and inactivate the microbes, but also begin to disassemble the biofilm matrix. And I think that capacity of oxidizing chemistries to do that is really important here. Efficacy is good with chlorine dioxide in terms of both breadth, including spores, but also sort of height, high-level efficacy can be achieved. Pretty good in the presence of organic matter. Every disinfectant is going to have reduced efficacy in soil conditions. It's a case of how much it's inhibited, and for chlorine dioxide, it's less than others. Low corrosivity compared with something like sodium hypochlorite, minimal harmful byproducts as well, so it sort of ticks the safety box, and supported by a growing evidence base. So just to kind of align the various options we might consider, I think chlorine dioxide performs well in terms of biofilm activity, organic load tolerance, more so than sodium hypochlorite or other chlorine-based chemistry. Safety, as I said, is good, as well as material compatibility. And again, I think material compatibility, because we're dealing with oxidizing chemistries, there's always a potential for it to be a problem with any chemistry. So I think it's an issue that needs to be managed and will be relatively good or bad depending on the chemistry chosen. We've rated the efficacy for all of these chemistries as weak at the moment. There's a lot of work that's coming through, but there needs to be more to really be convincing for broad application.
Thanks, John. So I'm just going to close with some research that I published recently in the Journal of Hospital Infection, which showed the activity of different chlorine dioxide applications against 2 different microorganisms in biofilm, Pseudomonas and Staph aureus. You can see there lots of different presentations from wipes to liquids, but chlorine dioxide performed really well, really high log reductions. And so we're kind of starting to see this evidence now appear. So you can go and check this out in Journal of Hospital Infection if you want to read it for yourselves. And again, high log reduction and low contact time, so really good efficacy from that perspective. We also did some pre-testing around how the chemistry works against lots of different multi-drug resistant organisms as well. And again, really high log reductions in low contact times. So just to close, and I think we'll have time for maybe 1 or 2 questions. These are kind of our summary, but we've also put some recommendations on there. Thank you so much for all participating in the poll. It's been really good to hear your thoughts. So we know the evidence base is building. We know drains and biofilms are a reservoir of infection. And we've tried to highlight some of the options that are there for you in terms of chemical thermal removal or some innovative techniques. And we've hopefully identified some of the evidence that's emerging for chlorine dioxide as a potential candidate for a chemical disinfection. But think back to that checklist when you speak to your manufacturers about what you need from a disinfectant. Efficacy, foaming, material compatibility, safety. It's a big list, so it's a big challenge for them. What do we want to see in the future? We'd like to see some standardization around efficacy tests, the importance of innovation and working with our corporate partners. I encourage you to go and visit the exhibition and speak to people who are innovating in this space, because we need to work with that sector. And we need to think about design in the future as well. We've got this initiative of the New Hospitals Programme, so we want to make sure that we are engineering out risk where possible when it comes to biofilms and sinks. And that's it from John and I. Thank you so much for listening.